All right, everybody, it's time to stand up. So I'm going to teach you the easiest Latin dance that I know. And I am not an expert, but this is bachata. And everybody's standing. You need to be able to move to the side, but we're all going to move to the side together. So we're going to go this way first. And you just step once, step together. Step twice, step together. This way, step once, step together. Step again, step together. And now with music. This way, 2, 1, 2, 1, 2. Yes! Good job, everybody. Some people are better than others. All right. So I'm going to introduce, keep dancing. I'm going to introduce our panelists. Keep dancing. Okay, Dominique, Zwinkels, raise your hand. Since 2016, Dominique has been responsible for the management and overall performance of People That Deliver, a broad coalition of 30 organizations working together to raise the profile of the health supply chain workforce as a key strategic area of health systems. Prior to PTD, she worked for 10 years on the HIV/AIDS supply chain at the Partnership for Supply Chain Management, which procured and delivered essential life-saving medicines and related commodities to HIV/AIDS programs around the world. Woo! All right. Thank you very much. I'll take the rest from the chair. All right, we also have Rebecca Alban. Can you raise your hand, please? Rebecca is a senior manager on the health system teams at VillageReach and leads their human resources for health portfolio, which has a focus on building a skilled, sustainable supply chain workforce. She's been creating, implementing supply chain workforce development projects for over 10 years. Kikelomo Lambo is a health system strengthening expert with CHAI. She leads a team that provides strategic and technical guidance to the government of Nigeria on new vaccines introduction, immunization supply chain, immunization financing, service delivery, campaign effectiveness, and capacity strengthening. Kike coordinates CHAI's technical support to the government for the development, alignment, implementation, and tracking of the 10-year plan for Nigeria's transition from Gavi support, totaling an investment of 1.03 billion into Nigeria's immunization system by Gavi to ensure a successful transition from Gavi support by 2028. Kevin Etter is an independent supply chain and leadership development consultant with 35 years of private sector supply chain experience. I had the pleasure of working with Kevin at Gavi. Did I miss anybody? Whew. So today, these 5 presenters are each going to put forward Jhilmil. I knew I missed somebody. Jhilmil Bahl, thank you. Works as a capacity building officer at the World Health Organization, Geneva. She's spent over 25 years of experience in supporting immunization programs and developing and implementing staff performance improvement strategies. She holds a master's in public health from London School of Hygiene and Tropical Medicine and master's in instructional technology from Syracuse University. So thank you to all of you for joining, and they are each going to have 6 minutes to present a key recommendation from the work that they are presenting or bringing forward here. So without further ado, over to Dominique.
Thank you, Joanie. Slides? No. Yeah. Okay. Okay, great. Again, thank you, Joanie. No,
Oh.
go back to my recommendation, please.
Okay.
Okay, so my recommendation to the audience is to think about workforce development through this lens of looking at staffing, skills, working conditions, and motivation. We want to ensure that these are present so that workers at every level are performing optimally and running an effective supply chain system. At the core of workforce development, we are building a strong and qualified supply chain workforce that meets the needs of our communities. And so when we're thinking about these workers, we're thinking about those that are collectively working together to ensure that the commodities are appropriately selected, they're forecasted, they're procured, they're stored, they're distributed, and of course that we're looking at the use of health products. We've heard a lot about community health workers in the last day. We've heard a lot about health workers. Here today, I am advocating for better investments in the health supply chain workforce. Next slide, please. And so I'm here representing the people that deliver. We are the global technical leader in human resources for supply chain management, the only global body that brings together governments, donor agencies, the private sector, technical organizations, and educational providers to address the people working in health supply chains in low and middle income countries. We are the conveners of diverse information, the leaders in diverse organization, the leaders in technical information, and the advocates for supply chain professionals. Next slide, please. You'll see here the strength of people that deliver is in our coalition members. We're 30 organizations and growing, and you'll see many of them are here today as well. And basically, what I wanted to mention was that we as the coalition, we build on the experiences of our members to advocate for change at global and local levels. This really results in a stronger and more sustainable system that can then help to develop, recruit, and retain the supply chain workforce. Next slide, please. And so I wanted to bring forward to you two resources. Actually, there was a third. I'm not going to have enough time in my 6 minutes to talk about that one. But this is at the core, at the foundation of our work. And we build human resources for health supply chain management through our theory of change, through these 4 pathways that I set out. So we look at staffing, skills, working conditions, and motivation. When we think about staffing, what do we think about? We think about recruitment and retention. We want to ensure that staff are not overloaded with work. We want to ensure that they have the right responsibilities and roles. Under skills, we're looking at skills development. We've heard a lot about ensuring that we're upskilling. We're looking at the data management, new data science, contracting, et cetera. Under working conditions, we often think about infrastructure. Today I heard about, do the healthcare workers have laptops? But we also have to think about, especially during COVID, the emotional support they're receiving in the workplace. In motivation, we think about performance management, supportive supervision. We think about our salaries, our non-financial incentives, thinking about the rewards, recognition that we need to be given. Next slide, please. And so the other approach I wanted to also mention here is the training needs analysis. Of course, this is the method of determining if a training need exists, and if it does, what training is required to fill that gap. UNICEF has developed a training needs analysis toolkit, which uses actually the people that deliver framework to assess the different competencies. So what's important here is to think about, is the lack of training really an important causal factor for poor system performance? And will that problem be solved by training? Next slide, please. So quickly, the example I wanted to provide here is Nepal. Nepal simply basically has a very young supply chain management system. I want to direct your attention to the bottom. The lack of resources is their big challenge. There's a shortage of staff. The staff that do work in supply chain management are overloaded. There's lack of training programs. Basically, there is no formal supply chain training in Nepal. And then, of course, there's lack of data monitoring. And I want to also direct your attention to the right-hand corner. When we look at the 4 pathways, skills is at 43%. So what we recommend is improving mentoring programs, coaching programs, developing very specific certificate programs with national universities. Next slide. This basically shows our recommendations would then lead towards wanting to introduce supply chain management professionalization. We need to ensure they have the recognition, are the cadres of workers that should be professionalized. And so next slide, please. And so if you're interested, I'm going to put a plug in. If you're interested in this topic, we would welcome you to attend the PTD Global Indaba in Thailand next year. This will be a forum to talk about this topic. Thank you.
Fabulous, right on time. Thank you so much.
So just building on what Dominique said, so my recommendation is that countries should transition to using evidence-based high-impact interventions to improve health worker performance. And notice that I am talking about health worker performance and not just training. So you would ask me, like, so where is the evidence? Where do we find evidence on high-impact interventions? So if you go to the next slide, please. So there was a systematic review done by colleagues at CDC, Alex Rowe and his colleagues, which looked at publications, published literature on the effectiveness of strategies to improve healthcare provider practices in low and middle income countries. And this was a very large review that was undertaken. It looked at over 200,000 citations, selected over 600 reports from 337 studies, and looked at over 100 strategies. So you can see the extent they went to. And what they find is that just providing printed and digital materials has only 1 percentage point improvement in the staff performance. Now, that we all know, it's not such a big news, and we never do that, right? We never just give guidance materials and publications. We do better than that. But at country level, there is only training happening sometimes, and that too does not have too much of an impact on staff performance improvement. Training combined with supportive supervision is better, but not spectacular. And what we see is that if training, if we move further and we go towards some of the good practices that evidence shows has had good impact, then we see group problem solving along with training has an impact. So I see Eric saying, yeah, so big deal. So within that also, there are certain types of group problem solving, like quality collaboratives combined with training have an even bigger impact. And then there are certain multidimensional complex interventions that have proven to be effective, but not all of them. But if the combination is right, they have a good impact, like training, combining it with supervision, combining it with providing the infrastructure and motivation that Dominique, you talked about, the motivation coming from internal and external incentives could have a huge impact. So next slide. And so what are some of the do's and don'ts that come out directly from this review? So in terms of do's, select interventions based on formal or informal needs assessment, as Dominique also mentioned, and use a multifaceted strategies for high impact. And you will hear from Kevin about the STEP program, which is actually combining these approaches. And there is a lot of training happening, and we can't really get away from that, but we can make it more effective. And what evidence has shown is if training is combined with other strategies, supportive supervision, group problem solving, it's more effective. And if it's conducted in the site, or at least provides the same conditions that health workers usually work in, it has a greater impact. And if it includes skills practice, an opportunity for health workers to actually practice what they've been shown, has a bigger impact. And then we go to what doesn't work, and you know that from the systematic review, just only training, only supervision has limited impact. And in-service group training, which is lecture-based, has found to be have a very modest impact, but it also wanes over time. It becomes, people forget. So that might not be the best way to just provide staff support. So next slide. I'll go, because I have very limited time, very quickly. I just want to mention that Gavi Alliance partners are taking this systematic review very seriously, and have formed a learning and performance management working group, which comprises of various alliance partners, and have come up with these 5 guiding principles for any training interventions, staff development and performance improvement interventions. And these are, they should be impactful, country-driven, sustainable, learner-centric, and digitally supported. In the interest of time, I won't be able to go and explain each of them, but I just want to again focus on the impactful. So we need to move away from just measuring the output in terms of number of people trained, to something which is more going towards strategies that are impactful, and there is an evidence to support that they would be effective. So since we are spending so much time and resources, let's spend it in the ways that is useful for the countries. Thank you.
Thank you so much, Jhilmil. Rebecca.
Thanks, everyone. I think my recommendation actually follows and reinforces Dominique's and Jhilmil's presentation perfectly, because it is that capacity development for supply chain workforce is not just training. It has to be more than that. And what I'd like to focus on is that it's also about building the right educational and career paths, so that once people enter the workforce, they don't actually need as much top-up training going forward. So I want to take a look just for a moment at that career path. If we could go to the next slide. Nope, that's not it. There we go. So if we can look at this visual and just think about it as it were any career path. Starting at the left-hand side, you are at the beginning, you're young and idealistic and thinking about what you want to do with your life. What will I choose to do? And then moving along to the right, you choose maybe a certificate, you choose a 2-year or 4-year degree, and move continually toward the right. You get a few years of work under your belt, you start to specialize, you get more training, and you move forward with your career. So looking at this pathway, and the workforce interventions that we have currently for building supply chain capacity, I'd argue that a lot of them right now are focused in the middle of that graphic. So when people are on the job, and giving them that top-up training to make sure that they have the skills that they need to do once they're on the job, which is incredibly important, and that's something I do and our organization does. But I would also say in a way, it's a band-aid to a systemic problem that people are entering the workforce without the skills that they need. So how do we break this training cycle? And that's a question I've heard many donors ask to me. How do we stop paying for all of these trainings? And my response would be that we focus more on the left-hand side of this graphic and look at getting people on the right educational and career paths early from their youth, so that they enter their workforce with the skills and the knowledge that they need to carry out these supply chain roles. And this requires a couple of things. It requires promoting awareness of supply chain management as a career path, which I know a lot of us are involved with in our various projects. And it also forces us to look at the current educational options, the degree programs, the certificates, bachelor's and master's, to make sure that supply chain management is there. Do we need to create new degree programs to make sure they're up to date and to make sure that they're of good quality? And this is not easy work. It's systems building work, but I think this is how we go about it and break that training cycle. Next slide. So I want to give a few examples of VillageReach's work and how we're shaping educational pathways. The first is in Mozambique, where we're working with the University of Health Sciences to create the first bachelor's in health logistics, which is an exciting consultation that we have with the Ministry of Health and other partners. And the Ministry of Health is very excited about this because that means for them, once this degree program starts, that they will have a pipeline of qualified supply chain staff that they can bring on and hire. In Malawi, we're doing a couple things. We've first worked with the Malawi College of Health Sciences to create a 2-year program for pharmacy assistants, who is a cadre that's specifically trained in supply chain to help the pharmacist. So the pharmacists don't have to take on all the supply chain responsibilities and can do what they really need to focus on, which is pharmacy. We also have a long-term partnership with Help Logistics, who are coming in to look at all the different curricula that exist in Malawi and do an assessment to review both the quality of the programs, make sure that they're aligned, and that once people graduate from these programs, they have the skills that the Ministry of Health actually needs. So trying to do that matching exercise of what the Ministry of Health needs and are the people graduating going to get those skills. And in the DRC, we're working with the University of Health Sciences and Empower School of Health to revise their bachelor's degree program, and also adding a component to capacitate the lecturers so that they actually have the skills to teach the program once it's created. So I just wanted to highlight those pieces of work because it's exciting what we're doing, but I think it's also representative of what the needs are out there. This is what we're doing in these 3 countries, but the more and more work we're doing, we're hearing that these needs are everywhere, lots of universities and across Africa. So there's opportunities for others in this room to build on this work. Next slide. Okay, I think I have 10 seconds, but I did want to mention gender because it's an important component. Okay. We need to proactively look at ways to bring more women into supply chain management roles so they're better represented across the board, but particularly in leadership roles. So we see lots of opportunities here for further engagement with universities, looking at how they recruit and sensitize people to their programs, opportunities to bring more women in, incentivizing them to participate. And another opportunity is looking at internship programs that focus on getting women involved. And so the one I've got on this slide is called Girls on the Move. And VillageReach is looking at ways to expand that program to reach more women and bring them into the supply chain profession. So I'll stop there. Thanks. Over.
Thank you so much, Rebecca. And on to you, Kike.
So I'd like to start off with an inference from the PhD exemplars. And it says countries where leaders are more intentional at improving healthcare worker motivation are also the countries with overall better health systems. Is this true? I think yesterday, Daniel had started off by saying that healthcare workers can positively advocate. Can they really? If we would say yes to that, shouldn't they be motivated enough to actually positively advocate? I think Elena also mentioned today that our workforce is insufficient. If we all agree that the workforce is insufficient, perhaps one healthcare worker is doing 10 people's jobs, shouldn't they be motivated enough to continue on the path that they are? Next slide, please. I want to share a case study of Nigeria and how the country was able to successfully motivate healthcare workers during the height of the pandemic. But maybe before we digress a little into that, let's look at what we are actually talking about. We're talking about a country with over 200 million people. We're talking about a country that has a birth cohort of about 8 million children annually. We're talking about a country with an infant mortality rate of 72 children for every 1,000 live births. If you do the mathematics, we're talking about a country that over 500,000 children born annually die. The health system is labor and capital intensive. We would all agree with that. But a lot of what we are seeing now, a lot of what the research is showing us, is that there is a direct correlation between service delivery and the motivation of our healthcare workers. This is manifested in their behaviors. The way the healthcare workers behave determine access and uptake of services. I mean, if you look at the quality of health services that are being provided, the efficacy, the efficiency, accessibility, it's dependent on the performance of these healthcare professionals. Shouldn't we consider their motivation, perhaps as a policy issue, as the case may be? Next slide, please. In the middle of last year, in the height of the pandemic, we found out that while the COVID pandemic continued to rage, the coverage of COVID stagnated in Nigeria. We couldn't get it up, we couldn't get it down, but we couldn't get it up. And so there was a deep dive done to understand what the enablers or the disenablers to this really was. And the findings were very clear. Healthcare workers didn't want to vaccinate. And they didn't want to vaccinate because they were not being remunerated on time and in full. And so part of what the government of Nigeria did, with support from many partners, WHO, UNICEF, CHAI, was to sit with these healthcare workers to say, how can we better improve and motivate you to conduct these services? It took a lot. We put into consideration technology for health, designing systems that enabled real-time visibility, triangulation to enhance prompt payments. And part of what we saw months later was an increase in coverage. Healthcare workers were motivated to start to deliver those services. But that's not really what we wanted to emphasize on here. Next slide, please. Of course, like my colleagues have also mentioned, several performance-based incentive mechanisms were put in place as tools for motivation. Healthcare workers were being paid, they were being compensated, as the case may be. But I think for us, the learning here is oftentimes we so easily forget who the healthcare workers are. I have 2 toddlers, and when my oldest toddler tried to make me explain the meaning of a compound word to her, I try to break it down in a way that she can understand. Her words are very simple: milkshake, football, applesauce. But I want us to try to break down our own word in this room today, healthcare workers. Let's take away health from the word. What do we get? What do we get? Care workers, right? Still makes some sense. Let's take away care from the word. What do we get? What do we get? We oftentimes forget that healthcare workers are also workers. And if workers from every industry are getting motivated, compensated, remunerated on time, fairly, trained, shouldn't the people whom we're entrusting the responsibility of reducing, for example, in Nigeria, the deaths of 570,000 children, or the people who are entrusting with the responsibility of a healthy population, also be remunerated? I guess, the action here is, as all of us continue to support our countries, and many of the countries that we support come into play here, we need to make sure that as we're supporting the government to design gender intentional, gender transformational programs, we're also programming for the healthcare workers who actually deliver these services. Thank you.
Thank you so much, Kike. Kevin.
Yes, excellent. And thank you, everybody. And, what a great panel, what great examples. I'm going to pivot just a little bit I'm going to use a workforce development example, but I want to really address a different challenge. And that challenge is, how can we scale and sustain a successful program after its pilot period or after its proof of concept period has come to an end? And so we've got a couple recommendations around that. The first one is that leadership and change management workforce development interventions, they provide a safe place to collaborate. And I'll get into what that means a little bit in the coming slides. We need to, as part of the recommendation, we need to leverage the power of multi-organizational, multi-sectorial collaborations to both sustain and scale workforce development interventions. And so what I want to use, Joanie, if you'll move on to the next slide, I'll use an existing program that began with Gavi way back in 2015, 2014 were some of the early parts of it. And I want to take us on a very short journey in the 9 years that program has been around. And while it was in development during late 2014 and through 2015, it was actually launched in 2016. And I'm referring to what we know now as STEP, which was the Strategic Training Executive Program. Okay? And that, as I said, that I'm going to walk you through the journey that we took each step of the way, right? In 4 minutes now. But think about this. STEP was designed in 2015. It was released in 2016. And the very first edition of STEP really lasted 2016 to 2020. It was in parallel with Gavi 4.0, the fourth generation of Gavi. Well, then an interesting thing happened in 2019. In 2019, as Gavi was preparing to go in from Gavi 4.0 to Gavi 5.0, they did an assessment to see which programs would move forward. And they made the decision that STEP would be a program that would continue into Gavi 5.0. However, they wanted to make some changes to it. And those changes really were around two ideas. How do we ensure sustainability of the program? And how do we enable scalability? So the period of time, the global pandemic that we went through, we took the opportunity to rethink STEP and to issue and develop and release a second version of STEP that we now call STEP 2.0. And it's that journey that I really quickly want to summarize, because it illustrates how the power of multiple organizations, multiple sectors can really have an impact on our workforce development programs. The very first thing that we did is we said, in order to enable scalability, in order to reach more people, in order to bring the program to more countries, more regions, more people, we need to bring more donor groups on board. So that was one of the first things we did. So now STEP is no longer a Gavi-only program. Gavi is a member of a donor consortium that consists of the Global Fund, USAID, an organization called IFPW, the International Federation of Pharmaceutical Wholesalers, and most recently UNICEF. And we are certainly open to adding additional donors. But you now have a group of people, a group of donor organizations that are offering this. And of course, when you've got a multiple donor organization, you have to have a governance body. And that's people that deliver. They act as the secretariat. So very quickly, I've got my yellow card up. So anyway, the content for STEP 2.0 was really pulled from 4 different programs. and the contributors, and that's the part that I really want to drive home. One of the things we wanted to do is reach out and have a broad base of contributors to the program. So you see donors, you see implementing partners, you see academia, and you see the private sector as part of that. And the last thing I want to draw your attention to on this slide is you can see the meteoric uptick once we brought additional donors on. So now we are scaling it. That's that box you see. We are, and obviously when we're spread across multiple donors, we're sustaining it. So next slide. So in conclusion, leadership and change management workforce development interventions are a safe place for collaboration with other donors, with implementing partners, with academia, and with the private sector. It requires a governing body, and our closing thoughts is why don't we see more cross-organizational, cross-sectorial collaboration in this space? Thank you.
Thank you, Kevin, and thank you so much to all the panelists. You guys are fabulous, right on time. We have 15 minutes now to engage all of you in discussion. We welcome questions, but we also welcome your thoughts and inputs from your own experience and work as well.
If you don't ask questions, she'll make us dance again.
Analea, followed by Srihari.
So first of all, thank you, because each of the recommendations were really interesting and really well justified. But I wanted to ask about motivation, because I fully agree that clearly it makes sense that putting more importance on making sure that health workers are well remunerated, as well as, given cash incentives, that would have enormous impact. And so would, of course, improve training. But I was just wondering how much more consideration is given also to the thinking around the burden on health workers and the expectations that we're placing on them, and how much is that being really explored and considered as a factor of motivation, or in fact demotivation, as the case possibly is.
Let's take 2 or 3 and then we'll answer those. So Srihari is next.
Yeah, I have a question for the, means in terms of motivation, specifically Dominique, what she mentioned, motivation. So the motivation and performance, they are very much linked. Motivation can be your working environment, motivation can be your salary, motivation can be the conducive environment in which you work. If health workers, if you talk about health workers, they don't have a conducive work environment where they can go for a toilet. Okay, so that for some worker, that is the biggest motivation. So I means, and what we are doing to improve the working condition. There are a lot of workload. They are overwhelmed. All these things are there. So there are some basic minimum standards for every human being. We talk of human rights, but why you are not working on those motivational environment instead of cash incentive? I'm not denying cash incentive is not good, but I think especially SBC, our SBC colleagues, they might have done a lot of research what motivate a people or a person. So which are the easy to target, which are sustainable to maintain, and where government need to pay, not partners or donors, because partner donors driven program never sustainable. Thank you.
I don't know. Can you yell?
Focus of the World Health Assembly was actually on human resource. And they did produce like a fantastic report with a number of recommendations that was endorsed by the different head of states. So I want to know the situation, what mechanism were put in place to actually track that. And the second thing is we know WHO kind of established indicators, at least telling countries that these are the norms. You need this number of healthcare workers for this number of populations. So what mechanism do they put in place to ensure that countries actually implement these? Are there mechanisms to track this, to get the global audience informed about the progress and so on? And the last question actually concerns the dynamics that we see in country. Because if you take healthcare workers per se, we can have broadly three categories. A group managed by the government, these are civil servants, a group managed by the public sector, and a group managed by either the private for profit or private for non-profit, like NGOs, faith-based organizations, and so on. And the reality is, condition of work, remuneration for all these cadres differ. Right, so I think there is that need to really study these dynamics well, and then see how to come out with recommendations that will reflect the challenges of the 21st century. And in particular, taking into consideration the increasing workload for healthcare workers, which will need to be factored in government plans and in plans of different organizations.
Thank you, Dr. Yawa. Who would like to take Analea's question? Kike?
Thank you so much for your question. I think, let's, to be a little bit clear, paying people for their work is not the only tool to motivate them. Training people is not the only tool to motivate them. I like the way you had put it. There are several factors, and if you deep dive into the individual country context, you'd find those factors. In Nigeria, the government took a decision, for example, to revitalize 10,000 primary healthcare centers. And in doing that, they did a deep dive to understand why some healthcare workers didn't want to go to certain place. And guess what the biggest drawback was? Electricity. The doctors say, we can't charge our phones. Why would we go there? So there are many factors that motivate or demotivate people, as the case may be. Part of what we are saying on this group is we have a responsibility to help our partner governments understand these factors and address them. And I think Dominique had mentioned quite a few. I think the only thing that we had also tried to do was to call out some of the biggest factors that we are seeing currently, like Yauba puts it nicely. What are the current factors that are impairing our current century? But that doesn't negate the fact that there are several factors that demotivate our healthcare workers, and we have a responsibility to help our governments address some of those factors.
Thanks, Kike. And I think you addressed Srihari's point as well in that answer. WHO, thank you.
And just to add for the motivation, we are in a process of developing, reviving the supportive supervision guide, and there is a big focus on motivation. So we have to, so traditionally supportive supervision has only looked at performance and what they are doing correctly and what needs to be improved. But now we are trying to say, well, the supervisor, there's so many things, like you're saying, low-hanging. So supervisor can at least advocate for certain things to improve the motivation of staff, and it's sometimes also not just financial incentives. There could be incentives of bringing the team together, talking about their wellness, the problems they face in actually even coming to the health facility. So we're trying to make this supportive supervision a bit of a broader, taking all the broader aspects, which include motivation as well.
So we have 4 minutes left, and I want to take one more question.
Okay, so the other question is about the HRH. So yes, there is a health workforce department within WHO, and we collaborate a lot now with them. And the points that you raised, we are taking those into account and did some advocacy with Gavi. And so now Gavi in 6.0 is also looking at all the aspects that you mentioned about health workforce. and seeing how we can, how Gavi and alliance partners can work, particularly in the immunization area, to improve the health workers' workload, the quality, the quantity, so to look at it more holistically. So coming soon.
Thank you. Gentleman from UNICEF, am I correct?
Just a quick comment regarding this issue of, let's say, human resources for immunizations. We had the chance with the National Immunization Strategy development in the last 2 years to have situation analysis. Then after that, exercise for prioritizations. We realized in several countries that human resources was coming first. And in this human resources, one of the points between, let's say, the availability of human resources, capacity building, supervision, then the issue of availability or distribution was even coming first. There's no need to go for many countries. Philippines are exporting to Middle East their own workers, Tajikistan, Kyrgyzstan to Russia, and many other countries. I think it is probably, to me, I won't say a time ticking bomb, but that is something which is super important that probably I don't say we have been underestimated in recent years, but needs in the strategy to be taken. And let's be frank, the issue is really an issue of how some health workers, as you rightly mentioned, are properly paid on time. For the rest, the motivations will come. Thank you.
Thank you very much. Shall someone want to respond, or we'll have one more from the audience? Dorothy?
Yes, thank you very much for the very inspiring recommendation. I would just thinking about supportive supervision, we have been talking about the model of supportive supervision for so many years. I don't know to which extent you have evaluated the quality of the system, of the way that countries currently implement supervision or supportive supervision. Maybe looking at the private sector, we got some inspiration around performance coaching, looking at to which extent the supervisor can become coach, considering the multiple factors, motivational, as you mentioned, internal, external, and all the conditions that we can support better the health workers to perform properly. So I didn't hear this very much. I think that with the STEP, this is currently really focusing on the capacity of leaders, how to lead your team, and how you bring this coaching approach in the way that you work. But probably from our experience, I mean, at Ganeshed, we have been supporting Senegal to introduce performance coaching into the supportive supervision, even digitalization also. What would be your recommendation on that in terms of transforming or encouraging countries to innovate, to bring new ways to support the health workers in the performance of their daily work?
Does somebody want a final word in response to that?
I think they were very good comments, and I think we have to work together to, each of us is advocate in our own right to kind of improve the current status of health workforce. Yeah.
Thank you again so much to our panel, and thanks to the audience.
Let's applaud again Joanie and the panelists for the exit, for fantastic discussion.